Hi, everyone. Thank you for joining me. My name is Randi Pochtar, and I am a psychologist here at the Child Study Center. I work primarily on our anxiety and mood disorder service, meaning that I work with children, teens, and young adults with a range of anxiety and mood disorders, and I also participate as part of our adolescent dialectical behavior therapy team, which I'll be speaking about over the course of this presentation. So you can submit questions at any time today by typing them into the questions panel of the control panel. That's on the right side of your screen. We'll answer questions at the end of our presentation. So I'm going to provide an overview of the presentation. I'll be reviewing the what, who, when, how, and why of adolescent self-injury, some potential signs of self-injury in adolescents, some strategies for talking to teens about self-injury, and last, some of the types of treatments that we know are generally appropriate for the treatment of self-injury. So first, the what, who, when, how, and why of adolescent self-injury. So what is non-suicidal self-injury? And as you can see on the right side of the screen, there's been a number of terms used to define or describe self-injury. Those are things like deliberate self-harm or self-harm, self-injurious behavior, or abbreviated as SIB, self-mutilation, cutting, or non-suicidal self-injury, as you see on this screen. You'll generally see it in the research and literature as non-suicidal self-injury or self-injury. And so, similar to the way that there's been many terms, there's also been a lot of definitions of self-injury. And so one of the most commonly accepted current definitions is as follows: the deliberate self-inflicted destruction of body tissue resulting in immediate damage without suicidal intent and for purposes not culturally sanctioned. And this was created by the International Society for the Study of Self-Injury. And what this definition is basically saying is that this is harm that one does to their body intentionally that results in immediate damage of some sort, and it's done without the intent of trying to end their life, and for purposes not typically culturally sanctioned. So that would be things like tattoos or body piercings. So I'm now going to review some myths about self-injury. There's a lot of things that people sort of think about when they hear the word self-injury, and these are some of the common myths or misconceptions that we hear when we think about self-injury. One is that people do it to get attention. Another is that it's a failed suicide attempt, or in other words, people are attempting to end their life and aren't successful. That only females or girls self-injure. Another is that self-injury is untreatable. Another is that it's used to manipulate or sort of gain control of others. And another is that only individuals with a diagnosis of borderline personality disorder self-injure. And over the course of the presentation, I'm going to work to debunk a lot of these misconceptions that people have about self-injury. So what's included in self-injury? Self-injury can include a wide range of behaviors, but it's most commonly associated with the following: intentional cutting, carving, or puncturing of the skin, and that can be done with an array of different objects, things like knives, scissors, safety pins. It can also include scratching, even with the fingernails, burning or self-bruising, so using an object to sort of bang the body in order to create some type of bruising and harm. Self-injury can be performed on any part of the body. Most often occurs on the hands, wrists, stomach, and thighs. And again, as mentioned in the definition on the previous slide, tattoos and body piercings are usually not considered self-injurious unless they're done with the specific intention of causing harm to the body. Now I'm going to review some of what we know about the prevalence, the age of onset of self-injury, and the duration of self-injury. So in general, US studies tend to find that the lifetime prevalence rates of self-injury range from about 12 to 37% in secondary school populations, and from about 12 to 20% in young adult populations. Again, as you can see, this is quite a range, and that varies based on sort of how the study was done, what population they were looking at, and things like that. Age of onset. So in general, the research shows that the average age of onset is between about 11 and 15 years. That said, self-injury can start much younger, even as early as 7 in childhood. And it also sometimes doesn't start until much later in young adulthood or even into adulthood. How long does self-injury last? Really depends. Self-injury can last weeks, months, or years. For many, self-injury is more cyclical than it is linear. So what we see is that someone may self-harm for a period of time, stop and then resume it at a later date, sort of depending on what's going on in their life at a given time or what other sort of vulnerability factors are there. And last, sort of along those lines, we see that recovery from self-injury also tends to be more cyclical than it is linear, and that someone may have a lapse or a relapse, and that doesn't necessarily mean that they're back to their baseline of recovery. Now I'm going to review the why. Why do people self-injure? And I'm going to focus less on the sort of underlying reason why, and more on the factors that sort of maintain the behavior, so sort of the mechanisms or functions of the behavior. And so Knock and Prinstein conducted a study which they were evaluating 4 different functions of self-injury, and they were looking at these functions along 2 dimensions. So the first is automatic versus social, and the second is negative versus positive. And while I'm reviewing this slide, I want everyone to keep in mind that when we're talking about reinforcement, we're talking about anything that makes the behavior more likely to occur again in the future. So that's whether it's positive or negative. So automatic is basically referring to something that's reinforced by the individual, like sort of automatically as a result of the behavior. And social is something that's reinforced by the environment or by individuals in the environment. Now, positive versus negative. Positive reinforcement means that something is reinforced by the addition of a sort of desired or positive response, and negative is the removal of an aversive stimulus. So automatic positive reinforcement in that first box means that self-injury in this case is done to feel something. So in essence, the person self-injures, achieves some sort of desired physiological response from their body, and that makes the behavior more likely to occur again in the future. Automatic negative reinforcement, and this is the most common function that they find for self-injury, is used to stop or escape bad feelings. So essentially what we see here is that someone is experiencing often intense negative emotions, and this can be anger, guilt, sadness, shame. They engage in self-injury, they experience a reduction in that distress, and that leads to the behavior being more likely to occur in the future. We call that automatic negative reinforcement. Social positive reinforcement means that as a result of engaging in the behavior, the person experienced some positive reinforcement from the environment. So that could be something like warmth, caring in response to the self-harm that could make the behavior more likely to occur again. And last, social negative reinforcement, where we see the removal of an aversive stimulus from the environment. So that could be something like someone ends up not having to have sort of a big conflict with someone as a result of self-harming, that they get to escape that, or sort of escape some sort of punishment or consequence as a result of the self-injury. So those are the 4 main functions that we tend to see in why people self-injure. On this next slide, I'm going to be speaking about that most common type, the automatic negative reinforcement. And so I'm going to talk about this cycle of negative reinforcement and how it works and how it gets maintained. So there can be any stimulus, really. I have here argument with a friend because that's a common one that I see, but it can be argument with a parent, getting a bad grade, any conflict with a teacher, some sort of stimulus that leads to an emotional response, typically a negative emotional response. So here I have emotions like anger, sadness, frustration, or shame. Often that leads to high arousal in these teens, so they experience sort of a heightened emotional response. Many describe it as overwhelming emotion. That can lead to them engaging in the self-injury to try to lower that emotional intensity. And as a result of the self-injury, they experience temporary relief. So we know that it doesn't last long, but that temporary relief and sort of that, I got a little bit of that distress down, can be really reinforcing. And so that's part of what keeps that cycle going. In addition, if you think about sort of the beliefs that may come along with that, right? So if someone learns that by self-injuring, they experience some temporary relief, that can lead to sort of reinforcing beliefs like, I'm right, I can't tolerate these high emotions, I have to do something to stop it. And so it can also reinforce beliefs like that in addition to the behavior itself. So often people want to know, is self-injury contagious, right? And so I took a quote from the Cornell Research Program on Self-Injury and Recovery that states that the seemingly rapid spread of self-injury among community populations of youth suggests that there may be a social contagion factor at work. As you can see, I then go on to say that there is a lack of empirical data to test this assumption, but that said, studies of contagion among adolescents in clinical settings demonstrate that there is a tendency for NSSI to spread in the population. Anecdotal reports from adults working from youth in school settings seem to report a fad-like quality to the behavior. And in addition, some research studies of secondary school staff suggest that there may be one form of self-injury in which groups of youth are self-injuring sort of as part of their group membership. Again, not all teens, but there's suggestion that there may be sort of one form of self-injury that is done in this sort of more group way. Some research suggests that the increasing prevalence of self-injury in popular media, so things like movies, books, news reports, that these may also be playing a role in the spread of self-injury. And last, the internet appears to be somewhat of a gathering place for individuals who engage in NSSI. So if you think about, sort of social media these days and an adolescent who sort of feels, really alone in this behavior, they don't know anyone else who's engaging in this behavior, it makes sense that they might seek out a community of other people engaging this behavior online. Now I'm going to review a really important piece, which is the association between self-injury and suicidal thoughts or behaviors. First, I'm going to speak about how they're different. So first, how they're different is that self-injury, as we just discussed, is a behavior typically used to feel better or cope, right? The individual is often engaging in self-harm to experience a reduction in distress. On the other hand, suicide-related behaviors are undertaken with the intention of ending one's life, right? So it's the intent behind the behavior that is one of the big things that differentiates these two behaviors. Again, and along the same lines, the presence of self-injury doesn't necessarily indicate suicidal ideation. So it's not necessarily that an individual who's engaging in self-harm is also experiencing suicidal thoughts or engaging in any suicidal-related behaviors. But now, how are they related? So while it's not necessary, we see that it is common for both to occur together. So in the general population of NSSI users, about 35 to 40% will also report some suicidal ideation. In clinical populations, so that means individuals with multiple diagnoses who may be presenting sort of for treatment, about 65% of those who use NSSI regularly will report some suicidal thoughts or behaviors. In addition, while self-injury doesn't necessarily cause or lead to suicidal thoughts or behaviors, what we do see is that it tends to lower the inhibition to suicidal behaviors, or in other words, if an individual begins to feel suicidal and they've already practiced harming their bodies in multiple ways, they may find it easier to hurt themselves lethally. So it almost can have this habituation effect to injuring the body, which could make it more likely that person could engage in a suicidal behavior. And most important, because both self-injury and any suicidal thoughts and behaviors indicate pretty significant underlying distress for that individual, it's essential for a clinician to really thoroughly assess and evaluate whether self-injurious youth are also experiencing any suicidal thoughts or behaviors. So now I'm going to review some potential signs of self-injury in adolescents. So the first may seem obvious, but any marks on the arms, fists, or forearms opposite the dominant hand, those are common areas for self-injury. Again, however, remember from some of the previous information, evidence of self-injury can really appear anywhere on the body. Inappropriate dress for the season. So if there is an adolescent who is wearing long sleeves and pants during the summer when everyone else is in sort of shorts and t-shirts, that might be cause for alarm. Frequent use of wristbands or coverings. So an individual who's wearing a lot of wristbands taking up most of their forearm, that could be something to be thinking about. That said, there's a lot of teens who really like to wear a lot of wristbands or coverings. But again, just thinking about these sort of factors generally. An unwillingness to participate in events or activities that require less body coverage. So things like gym class or swim practice, where an individual is having to change in front of other teens or in front of others, or where they're having to wear something like a bathing suit or shorts that may show potential scars or cuts. If if you're seeing frequent bandages or other sort of odd instruments like razor blades or other instruments like, a taken apart pencil sharpener, things like that would be things that we want to be looking out for as potential signs of self-harm. And of course, thinking about any heightened signs of depression or anxiety in a teen. Now I'm going to speak about some strategies for talking about self-injury with adolescents. So some suggestions if you suspect or discover your child or adolescent is self-injuring. First, I want to say that I think that there's a few things that are more terrifying than finding out that your teen is hurting themselves intentionally. And so that can lead to a lot of feelings as a parent: denial, shock, anger, sadness, empathy, guilt. And so it's really important to take that time to observe your own thoughts and feelings about this when having difficult conversations with your teen. So really taking a moment to understand what's going on with me before sort of taking that next step to engage with your teen. Choose an appropriate time and place for the conversation, so make sure it's a private enough space where the teen will feel comfortable, making sure you have enough time to have the conversation, things like that, making sure all sort of electronic devices are put away, and that this is a clear, specific time for you to have an important conversation. Recognize that direct questions can feel invasive, even when that's not your intention. So you're going to want to know a lot of information and just being mindful of sort of the impact that may have on the adolescent. Be mindful of the level of shame and guilt that can be associated with these behaviors. So, especially for a teen talking to their parent or caregiver, someone who they know really cares about them and who they really care about, and this is maybe them sort of being discovered, a behavior that they've really been trying to keep private, there can be a lot of shame and guilt there around sort of what it means about them that they're using this behavior. And last, if you notice feelings of anger, frustration, judgment about your child while having this conversation, consider taking a break from the conversation. You can always come back once you're calmer. And it can be helpful to sort of model letting your teen know, I'm noticing that I'm getting a little upset. This is really hard for me. I really want to understand more, though. I'm going to take a little break and then come back when I'm calmer. I really want to understand this with you. Some further suggestions, and I put on here some do's and some don'ts. So some do's: address the issue as soon as possible. As mentioned on the previous slide, given what we know about the dangers of self-injury and its association with suicidality, it's really important to have this conversation sooner than later. Make eye contact, speak in a calm tone. I talk about being specific and honest about your concerns and why you have them. Teens are really good at reading through when adults are sort of dancing around things or sort of walking on eggshells. And it can be really important to make sure you're being direct and clear about why you have these concerns. Remain neutral and validate your child's feelings without necessarily agreeing with the behavior. So we can validate a person's feelings and what they're experiencing emotionally without necessarily agreeing with the use of self-injury as a coping mechanism. Ask for permission to ask certain questions. So you may say something like, I'm wondering if it's okay if I ask a few questions about why this works for you, that type of thing. Some don'ts, and these may seem really obvious, but when your anxiety is heightened, that can make you more likely to engage in behaviors that you may not typically want to. So things like yelling, blaming, or criticizing the child or adolescent can be problematic in these situations. Things like lectures, ultimatums, or threats are also often not helpful. Engaging in power struggles or attempts to control their behavior. Again, this behavior is scary, right? And so that can lead to parents wanting to do anything they can to stop it. And things like demanding answers, right? So again, you may want to know why, how long, how often, right, your teen is engaging in this behavior because you're going to want to have that information. And it's important to sort of respect what they're willing to disclose while also trying to get the information that you need to keep them safe. I talk about this idea of practicing respectful curiosity. So that questions about marks should be non-threatening and neutral. You want to both respect the teen and come across as curious and wondering and wanting to understand as opposed to sort of judgmental about the behavior. So what are some of the treatments for self-injury in adolescents? And I'm going to speak about a few different treatments, but first I want to review some questions to ask as you're beginning to look for a clinician potentially to treat your child. So there's a lot of therapists out there, and these can just be some initial helpful questions. So the first is, do you have experience treating adolescents? And while there are many people who treat both adults and adolescents, it can be helpful to know if someone regularly treats adolescents in their practice. Do you have experience treating self-injury? Again, wanting to get a sense of, does this person regularly and commonly treat this in their practice? And what do they do to treat it? And then there's two specific types of treatments, which I'm going to talk more about in the next few slides, that can be helpful to find out if a person has training and experience in. So those are dialectical behavior therapy and cognitive behavioral therapy. So dialectical behavior therapy, also known as DBT, is a comprehensive cognitive behavioral therapy for complex adolescents with multiple problems. So DBT is often appropriate for teens with some or all of the following behaviors. Pretty significant difficulty regulating their emotions, self-injurious behavior, teen who's had a history of suicidal thoughts or behaviors, impulsivity, so sort of believing that your teen is acting without thinking a lot, disordered eating, substance use, anxiety and mood disorders, as well as interpersonal difficulties and or family conflict. So, thinking about a teen who has a lot of difficulty regulating emotions and maybe engaging in impulsive behaviors, you could see how that could lead to some interpersonal difficulties and conflict within the family. A comprehensive outpatient DBT program is made up of 4 components. So that's individual therapy, and it's a really specific type of individual therapy specific to DBT, a multifamily skills group therapy. So that is group therapy done with both teens and their parents, where they're both learning specific strategies and skills designed to target the behaviors that I just mentioned, including self-injury. Phone coaching, so one unique part of DBT is that the therapist is available to the teen after hours to help them with skills generalization, and a DBT consultation team. So this is essentially all the therapists on a DBT team meet together at least once a week to make sure that they're providing the most effective therapy possible for the teens. Cognitive behavioral therapy, or CBT, is also, and similarly, an evidence-based treatment that focuses on developing skills to target problematic patterns that occur among our thoughts, feelings, and behaviors. CBT is an evidence-based approach that's been applied to a wide range of disorders and problems. And CBT, I generally say, may be appropriate for adolescents engaging in more mild NSSI or with fewer of the other problematic behaviors identified on that previous slide. Some factors like frequency, intensity, severity, and duration of NSSI are some things to consider when determining if CBT or DBT may be appropriate for a given child or adolescent. It's always recommended that you work with a mental health professional like a social worker or psychologist, psychiatrist, to determine if and what treatment may be appropriate for a particular child or adolescent. Last, I'm going to speak about psychopharmacological treatment. So I'm not a psychiatrist, and yet I work very closely with a lot of psychiatrists on a number of the adolescents and families that I work with. And the literature and research generally agree that there's no sort of agreed upon medication designed specifically for the treatment of non-suicidal self-injurious behavior. Rather, medication would be indicated to treat the underlying psychiatric disorder or the associated symptoms. So that could include things like depression, anxiety, ADHD, or associated symptoms, as mentioned, like emotion dysregulation, irritability, impulsivity, things like that. Again, always recommended that you work with a child and adolescent psychiatrist or other medical professional to determine whether and what medication may be most appropriate for your child or adolescent. And I have some references for you to be able to look at as you're going back and potentially want to find out some more information. And now I'm happy to take questions. So the first question is, how can I talk with my child in case the self-injury becomes an emergency? So for example, if a cut is too deep. This is a really important question. I'm glad that someone asked it. Definitely talking with your teen if you find out that they're self-injuring about what to do in case of an emergency is really important. A lot of people who self-injure sort of in a more regular way will report that at some point they self-injured deeper than they intended to, and many will also report that they don't seek out medical attention. And so one thing to do is to basically just be really direct and talk with your teen. If there is a time where you self-injure deeper than you mean to, these are some of the things that you're going to do, right? So have them identify who they're going to tell. So you, their therapist, thinking about also always knowing that 911 is an option, so they can always call 911 if they cut deeper than they intend to. And generally, you can also be speaking with your teens about just making sure that they're caring for open wounds effectively and safely. So making sure that they're cleaning them appropriately to reduce any risk of infection. So another question is, do you have any suggestions on how to approach my child if he or she has a friend or classmate that self-injures? This is also a really important question and a challenging one. You know, I think if your child or teen is approaching you about a friend or classmate that self-injures, you know, I think that you can be really validating and supportive to your teen about how hard this is. You know, certainly finding out potentially if that child is seeing someone, if they're getting help, and helping your child to recognize what their role is, right? I think sometimes children and teens really want to take on the role of being a support for their friends, right? And they, you know, sometimes can want to take that on more than adults would like them to. And so really helping them to recognize how they can both support their friend while also recognizing that they don't have the responsibility to do that. And I think helping them to figure out how to walk that line can be really important. I think it's really important, though, to validate how much your child cares about their friend as you start to have this conversation with them. Another question is, should parents wait to have that full conversation with their teen until a professional is involved? I think this is a really good question, and I would say it probably depends. Depends on the situation. You know, I think it would be difficult, I'm imagining, to, you know, have a teen attend a first therapy appointment or an evaluation without potentially having that conversation if there's no explanation why. Again, I think coming back to that sort of transparency and importance of being honest and direct, you know, I think that generally having that conversation as a means to helping them to understand why you're scheduling that appointment can be important. If there's other reasons why you're scheduling the appointment, then that may be a different story. But if this is the primary reason why you want your teen to see a professional, I think it might be challenging to get them to that appointment without being clear about some of the things that you've observed and some of your concerns. But again, I think it really depends on you and your child and sort of your comfort level in terms of having these conversations. So another question is, does hair pulling when stressed fall under the non-suicidal self-injury umbrella? And this is a really good question and one that comes up often, sometimes I guess I'll say. And my understanding is that there's sort of mixed thoughts and feelings about this. Hair pulling in the DSM falls under the restrictive repetitive body behaviors. And so it falls sort of under a different category and generally is treated somewhat differently than self-injury is. So again, we want to be thinking about while the function of the behavior may be to relieve distress, which is similar as I described to self-harm, the treatment and the intervention may be different. And so we generally conceptualize them somewhat differently, though they may serve a similar function. And again, since we're not seeing that like tissue damage that may occur in self-injury, that's another reason why it may not quite exactly fall under the same umbrella. I'm sorry, that's body-focused repetitive behaviors. I don't think I said that quite exactly correctly. Okay, another question is, what can you do to help or motivate a child learn the need to learn more effective coping strategies, right? So since self-harm is a relief to your child, and this is a really good question and something that we as clinicians are often working to do. So part of the treatment, part of DBT and part of CBT is helping to build that motivation. You know, we'll have a lot of children and teens who come in and say things like, you know, this is the only thing that works, right? They've tried lots of different things and they find that this is the one that's worked for them. And so it can be really hard to get them to give that up. And I think first thing is recognizing that that's what's true for them is a really important piece. Other things that, you know, therapists and parents can do to help their teens when they're having difficulty sort of motivating to use the other coping strategies. One way that I use is helping them to understand that negative reinforcement cycle, so helping them to understand how the more and more they do this, the more and more they're going to do it. And so the fact that their brain is essentially learning that they have to, escape negative emotions is an important thing for them to understand. And the more and more they refrain from the self-injury, their brain is going to learn that they don't need it as much. I also think getting them to try and buy into some of the alternative coping strategies is another way to help build that motivation. So if they can see that some of them can work, that can be really helpful. So those are some of the things that we want to be thinking about in helping to build motivation to stop the behavior. And I think there are other things that are going to be particular to that child, right? So sometimes it's helping them to recognize that they may not want these scars long term, that how it's getting in the way of their life, right? So how is self-harm not working for them? Those are some of the things that we want to be thinking about and thinking about how to motivate a child to stop self-injuring. And again, that's a great conversation to be having both with the child and with their therapist. So another question is, would you consider this an addictive personality trait? And have there been any long-term studies where adolescents who self-harm go on to be addicted to drugs or alcohol? This is a really good question. And I would say it's a little controversial on whether or not this sort of has an addictive quality. My understanding is that some of the research shows that there are individuals where sort of the need to self-injure can almost feel like an addiction. And interestingly, we do see that for individuals who self-injure more regularly, they'll often report that they need to self-injure more or deeper over time to get the same effect as they initially needed. Not sure about long-term studies where adolescents who self-harm go on to use drugs or alcohol. We do know that sometimes these behaviors occur at the same time, so there can be comorbidity between adolescents who self-harm and who also use substances or use alcohol, and that if they don't learn alternative coping strategies, this can lead to long-term problems in many areas. So I think that's sort of what I would respond to for that question. Okay, last questions. Do you have any resources, books, sites, et cetera, that you would recommend for parents dealing with a child that self-harms? Yes. So there is a book that I cite in my references slide by Dr. Hollander that is called Helping Teens Who Cut. That's a really helpful book for parents. I'm just going to go back for a second. Yeah, so that first reference at the top. Another great resource for understanding self-injury is the Cornell Research Program on Self-Injury and Recovery. They have an incredible wealth of resources on their website that are extremely parent, caregiver, and child school staff friendly. So those are two resources among many others that I would highly recommend. So I just want to say, on behalf of the Child Study Center, thank you so much for joining me today. Once you leave the webinar, you'll receive a survey, and we would appreciate if you would complete it. You will also receive a follow-up email within a day or two with a link of the recording from today's presentation. We really hope that you can join us for our next webinar entitled What is a Neuropsychological Evaluation by Helen Tam. That's on Tuesday, March 21st, 2017 at 1 p.m. Thank you again. Bye.